Beyond the Pelvis is hosted by Dr. Keneal Siegel, a pelvic floor PT and intuitive healer, and Laura Haraka, a somatic practitioner and breathwork facilitator. Each week, we explore alternative and holistic approaches to healing chronic pelvic pain and other painful or chronic conditions. Join us and other experts in mind, body, and spiritual healing as we discuss a wealth of modalities ranging from ancient practices to modern therapies that challenge the conventional Western model of treatment. Let's get right to it.
Welcome back to another episode of Beyond the Pelvis. And on today's episode, we're honored to have Dr. David Clarke, who is the president of the Association for the Treatment of Neuroplastic Symptoms. He is also assistant director at the Center for Ethics and clinical assistant professor of gastroenterology, Emeritus, both at Oregon Health and Science University in Portland, Oregon. Dr. Clarke has lectured extensively on neuroplastic symptoms across North America and in Europe, and has diagnosed and treated over 7,000 patients whose symptoms were not explained by organ disease or injury. Thank you so much for being here today.
Great to be with you. I appreciate your spreading the word about this.
As we start, can you just share a little bit about yourself, who you are, and maybe what brought you into this space?
You bet. Well, I'm a board certified in both internal medicine and gastroenterology. I practiced GI for 25, 30 years and encountered, as you mentioned, over 7,000 patients that my diagnostic evaluations didn't show an explanation for their symptoms. And this was about 1 out of 3 of my patients for all those decades. And the good news is that by knowing what to look for, you could diagnose and treat them as successfully as anybody else. These are what we call neuroplastic symptoms, neuro meaning brain and nervous system, and plastic being the medical jargon term for capacity for change. And I didn't know anything about this the first 7 years of my formal training. And, after 7 years, I thought I, knew what I was doing. But then in year number 8, out of 9, I encountered a patient I didn't know the first thing about diagnosing or treating. And she had been referred to us from another university. I was at UCLA at the time, and she came to us from another university where they could not figure out what in the world was wrong with her. She was averaging 1 bowel movement per month, despite taking 4 different laxatives at double the usual doses. And the other university sent her to us because we did this very specialized testing of the electrical activity and the muscle contractions in the large intestine. And my department chair and I, we knew that this test was going to be abnormal, that it was going to show what the problem was, because as far as we were concerned, no other explanation was possible. Because at the time we had an organ-based mindset. But when that test was normal too, we just were scratching our heads. I'd never seen anything like that before. A person with a severe problem and no explanation for it. And so I was doing her exit interview, essentially telling her, you're going to have to live with this, but not wanting the conversation to be over in 30 seconds, we started talking about stress, and eventually she began telling me about her having been sexually abused as a girl. Sadly, not just once or twice, which would have been bad enough, but hundreds of times. And I didn't know what to do with that information. Nobody had told me that I should be asking people about this. I didn't expect her to be talking about this. I was concerned if I got into a discussion about this, that it would make her worse, that she'd have a breakdown. But at the same time, here was this, incredible piece of information in a patient with no explanation for their symptoms. I didn't see how it could be connected. The abuse had stopped happening 25 years in the past, but at least it gave me a place to pass the buck, which was Harriet Kaplan, a psychiatrist at UCLA that was certified in medicine as well. And I thought, okay, I can send this patient to Harriet, and maybe she'll learn to live with her condition a little better. So I sent her, to see Harriet, forgot all about her, went about my fellowship training, and then ran into Harriet 3 months later in an elevator. which was the elevator ride that changed my career, because it turned out Harriet had cured this patient with less than 3 months of weekly counseling sessions. And that blew my mind as well, because again, here I am, year 8 of my training. Nobody has ever said you can do this, that you can alleviate a really bad physical condition just by talking to somebody. So, I wanted to be a complete doctor. I wanted to be able to handle, whatever came through my door. So I prevailed on Harriet to teach me the basic framework of how she thought about patients like this and what she did for them, never thinking I would use it myself. But when I got to Portland and started in practice, there were no Harriets here. And the patients would get cognitive behavioral therapy, and then they would come back and they weren't any better most of the time. So they were telling me, do you think you can help me? And I said, I'm really not sure, but I'll give it a shot. And I learned through trial and error. I learned through listening to people. I learned, to try something, see if it worked. And if it didn't, I'd drop it and try something else. And it took me 5 years to climb that learning curve. And that was another shock, which was that it was upwards of 250 or 300 patients a year with this. Not as bad as the first patient usually, but with very similar problems. And nobody told me that either. I thought it was going to be 2 or 3, 4 patients a year. It was 5 or 6 every week. And, I couldn't help but gradually improve. And eventually, after probably 5 years, I felt like I knew what I was doing. And, not coincidentally, I got an award as Doctor of the Year right after that happened. They found out that I was doing this, and they started sending me their mystery cases, and I was getting good results with them. That became a big chunk of my career after that. So a long-winded answer, but it kind of, gives you the idea of a pathway that a lot of people in this field have followed.
Wow, what an amazing story.
Yeah, I was so many things that I got wrong. It's almost embarrassing as a physician. Actually, it is embarrassing that I went so long in my training never having heard of this. And it's 40% of people that go to a primary care doctor that have these problems. How could you go through that much education and not be taught about this? It's almost double the number of diabetic patients out there. And, we medical types, we spend all kinds of time learning about diabetes. And this is almost twice as big in terms of the number of patients. We should be spending a ton of time teaching our healthcare professionals. And yet I get 1 hour a year to teach the medical students here.
Wow.
And even that, I had to bang on the doors for several years before they finally gave me that hour.
So I know now today you call it neuroplastic pain or neuroplastic symptoms, but what did you call it then? What was it to you?
Well, there's probably 12 or 15 different synonyms for this. I think, for millennia, it was called hysteria. There is actually an Egyptian papyrus from 1800 BC that describes these symptoms. And, they had treatment for it back then. And it was blamed on the uterus, which, fits into your line of work. It was blamed on the uterus wandering around inside the body, causing problems. Those darn uteruses. Very conveniently, half the population doesn't have them. So we don't have to be concerned about that in the male population, I guess. But that's the way they thought in 1800 BC. And rather remarkably, the thinking hasn't changed very much in almost 4,000 years. The treatments that most people get for this are no better than placebo. And that's the level of care that was provided by the ancient Egyptians too. There aren't many diseases where zero progress has been made in that length of time. So hysteria was the name for it for thousands of years because the Greek word for the uterus is hysteros. And so hysteria comes from that because the uterus was thought to be responsible for this. The word hysteria was not stricken from the medical literature until 1980. I mean, it was in the Diagnostic and Statistical Manual until I think it was number 3 that came out in 1980, and they finally took it out. So psychosomatic was another one, but nobody likes that term. We called it psychophysiologic because we were trying to educate our medical colleagues that this is both psychology and physiology. But the medical colleagues were not embracing that one. So we just recently changed to neuroplastic, which is more hopeful because it contains the medical term for change. And absolutely, patients can, even with severe cases, can be successfully treated. We can go through some of my more severe ones, but one woman, 79 years of unexplained abdominal pain, successfully treated.
Wow. So what are some of the techniques that, you said it took you a few years, a lot of trial and error, but what were you doing that was different?
Well, looking for sources of stress, I think, is how I would characterize it. And then once they were identified, treating them at various levels. And the most straightforward level is, self-care and ways to reduce the activation of the sympathetic nervous system and activate the parasympathetic nervous system. And I know Laura has used breath work, which absolutely fits right into that. It's often a very useful foundation for treatment. It's a form of self-care. That's, any kind of self-care is very important. But the main thing is to diagnose the sources of stress. And it can be stress in your life at the moment. One of my patients who was not diagnosed by the rest of the healthcare system was getting his abdominal pain when he was driving to work. He was not getting any pain when he was driving home from work. Not too difficult, but you have to know to look for that sort of thing.
Yeah.
Another patient, 25 years of low back pain. This, what is a gastroenterologist doing seeing a patient with 25 plus years of low back pain? But that was his main complaint, and he was a mystery patient. So they sent him to me to see if I could find anything. And I did. I found that it wasn't daily low back pain. He had 2 weeks out of the year when he felt fine. And what do you suppose he was doing during those 2 weeks out of the year? He was on vacation. Right. So, but I had to, not completely leap to conclusions, because it occurred to me, well, maybe he's lying on a warm beach somewhere, carefully resting his back. And that's why his back doesn't hurt when he's on vacation. It's not got anything to do with stress. It's about improvement in the care of his spine. So I said, well, what do you do on vacation, sir? And, he's 75 years old, and he goes fly fishing in British Columbia. So he's doing this kind of thing, and he's reaching down into the bait bucket, and he's netting the fish, and he's wading out into the stream in his waders and having to balance himself on the slippery rocks. And then he tells, I'm listening to this and I'm going, there is no way that he has structural back pain if he can do this and be pain-free. And while I'm reaching that conclusion, he confirms it for me by saying at the end of the day, he would help the lodge owner clear brush from behind the lodge. And so I'm going, and your back is okay while you're doing this? And he said, yeah, it feels great. So 100% that is not structural back pain. And so the solution to that is to recognize, where the stress is coming from. The back pain guy was, let's just say, a workaholic. And when he was not on vacation, he was working 6.5 days a week. He just pretty much never stopped. And no surprise when you talk to him about his early years, and adversity in childhood is a key factor for a lot of my patients. He had grown up working in the family business, starting at, early grade school. He told me he was carrying bags of mulch that weighed more than he did. So he developed a work ethic before he knew any better. And now he's 75 years old, and he's exactly the same. He never takes a break if he's not on vacation. And so his back hurts every day. So that's the first thing, stress in your life at the moment, and then stress when you were a child, any treatment as a child that you would never want for a child of your own. So that covers a lot of ground. A lot of people will look back and they'll say, well, this, that, and the other happened to me. It wasn't that great, but I think I'm over it. It wasn't that bad. Other people have been through worse and they seem to be okay. But then when I ask them, okay, how would you feel if you had to watch a child of your own in that same environment? You know, you're a butterfly on the wall of your childhood home, and you can't do anything but observe, and you are watching this kid try to cope with everything you had to cope with. Are you okay with that? Or are you feeling sad or angry about what you're watching? And that gives people a much different perspective, a much more accurate sense of how much they had to overcome. And those early issues we can't change them, obviously. We can't go back and do something about them, but we can absolutely help people with the long-term impact. And the long-term impact plays out in three major areas. Personality traits that are stressful, like perfectionism, low self-esteem, poor self-care skills, poor assertiveness, people-pleasing, detrimental levels of devotion to other people in your life, choosing less than ideal partners for yourself, a whole long list of stressful personality traits. Second area is to look for triggers, people, situations, or events that are particularly stressful for you because they have reminders or links to the mistreatment of the past. And then finally, and most challenging, something that I missed in my early few years of doing this work are unrecognized emotions. Obviously, negative emotions, anger, fear, shame, grief, guilt. I've seen all of those be responsible for physical symptoms. And the body has always been part of the expression of emotions. If you're in a tense situation and you get a knot in your abdomen, that's a brain to body neuroplastic type of symptom that most of us have experienced. This form of illness is just a more severe and long-lasting version of that very common phenomenon. And people can have those emotions and be completely unaware. And so as a treatment professional, you have to try to listen to their stories and listen for experiences they've had that would make most people angry, fearful, shamed, grief-stricken, or guilty, and begin to put it together that this person in front of you probably has that emotion in there. It's usually anger, but it can be any of the other ones. And they're just not aware of it. So it's manifesting in their bodies instead of in their conscious awareness. And then the last parts of my assessment, just really quickly, depression, anxiety, and post-traumatic stress, just to make sure that those haven't been missed, because they often are. Had plenty of patients over the years where they had any one of those three and the healthcare system had failed to diagnose it.
So I know a lot of people, doctors and coaches, get into this work when they've actually experienced mind body or neuroplastic pain themselves. And I don't know if this is too personal, but I know that I experienced chronic pelvic pain and now I'm doing really well, which is great. I've healed from that. But when I look back, I realized that I've had throughout my lifetime tons of neuroplastic symptoms. And I'm just curious if there's been any aha moments that you see now looking back.
Yeah, I'm sort of an oddball in this field in that I didn't suffer from this myself. I had to learn it from scratch. It came as a complete unknown to me in that 8th year of my training. And in doing this work, it's absolutely an advantage to have experienced it yourself. So it was almost an intellectual disability for me never to have had it. I couldn't call upon my own personal healing experience to help other people. I had to learn all of this from scratch, first from Harriet and then from my patients. And that's why it took me so long. But these ideas are so powerful that even as a bumbling beginner, I was getting better results than the rest of the healthcare system. This is back in the 1980s when I was seeing my initial 1,000 to 1,500 patients that I'm always especially grateful to for having helped me overcome my handicap.
What were some of the common symptoms, GI or otherwise, that you noticed that were showing up as neuroplastic
Yeah,
symptoms?
it certainly has started as the gastrointestinal ones, but many of the patients with the GI symptoms, which was the reason they were sent to me, also had other things, and they could be literally from head to toe. You can get migraines, ringing in the ears, dizziness, visual disturbances, trouble swallowing, temporomandibular joint problems, chest pain, pain pretty much anywhere, pelvis, persistent genital arousal disorder, pain in the genitals, bladder spasms, joint problems. The spine is big, both the cervical spine and the lumbar spine, very, very common. The GI symptoms, trouble swallowing, lump in your throat, reflux symptoms, not actual acid reflux, but the symptoms of acid reflux without the actual reflux going on. Nausea, vomiting. One of my patients had a completely paralyzed stomach. The severe constipation patient I mentioned, but it can go the other way, diarrhea, or it can go back and forth. One of my favorite stories was about a 16-year-old who had really severe diarrhea, but only on Tuesdays and Thursdays. Shows again the importance of getting the exact history. A large fraction, probably at least 50% of pelvic pain is neuroplastic in origin. There's a couple of studies on that specifically. What am I leaving out? Certain kinds of rashes. Mast cell activation syndrome is a rare condition, but symptoms similar to it can be neuroplastic. People who are labeled with chronic Lyme, they actually don't have chronic Lyme, but the number of symptoms that are blamed on chronic Lyme is 99% neuroplastic. Long COVID is another one. The number of symptoms blamed on long COVID is well over 100. And it's actually the case that most of those are neuroplastic, and there's research evidence accumulating about that now. So the list is, it kind of goes on and on. One of my patients had total body itching for 3 years, and by identifying the underlying stress, his symptoms were 95% relieved within 3 weeks.
I love that you mentioned specifically about pelvic pain, PGAD, because that's what the diagnosis that I was given and that I healed from. And a lot of people think that that it can happen from going off antidepressants or other types of medications. And I'm just wondering, with your clients with pelvic pain in particularly, what percentage of them do you think have healed from this mind-body approach?
Oh, I would say the vast majority. Unfortunately, the nature of my practice was that once the diagnosis was made, I would turn them over to available resources to continue their treatment, but I wasn't able to treat them myself. My turnover in my patients was extremely rapid. The average number of visits that I had with a neuroplastic patient was 1.8. So, had to get a lot of diagnostic information and get the patient pointed in the right direction very quickly. But when you saw the look of self-recognition on the patient when the underlying stresses were identified and brought into their conscious awareness. I had a relationship with a gynecologist whom I never actually met in person, spoke to on the phone. He was across town, spoke to him on the phone, emailed back and forth. And he and I got into this pattern where patients would be referred to him for pelvic pain. He would do a diagnostic evaluation and sometimes treatment and not have success. He either wouldn't find anything wrong, or he would find maybe some mild endometriosis and treat it non-invasively and wouldn't get any improvement. So he would be planning to do a laparoscopy on them, which for your listeners who are not familiar, it's where you make a small incision, you put a lighted metal tube, and you look around inside the pelvis to see what you can find that might be wrong. He would schedule the laparoscopy for a couple of weeks down the road, and we would arrange for the patient to see me beforehand. And so the plan was that if I could find a neuroplastic cause for the patient's pain, he would cancel the laparoscopy. And not a single one of those referrals ever got a laparoscopy. I mean, these were people who had pelvic pain and a negative non-invasive evaluation. So the pelvic exam, the ultrasounds, sometimes an MRI, either would show nothing wrong or would show very little wrong, maybe a small ovarian cyst or a small amount of endometriosis, something like that, but nothing that would seem to account for the level of the patient's symptoms. And they would all have one or more of the sources of stress that I was listing earlier. And I'd get them started on treatment for it, and they would make progress, and they never got the laparoscopy.
Wow. So what does your treatment consist of? I know you mentioned that you wouldn't see them that long. You would sort of refer them. Who were you referring them to? Like what kind of services or people were they going to or following up with?
Yeah, mostly I would try to help them identify what the important issues were so that when they did go to a mental health professional, they would get attention paid to that. The cognitive behavioral therapy and the research confirms this, is not good enough for this. So I would try to identify, and the most of the time it was a childhood stress issue that the patient had not recognized the importance of. So many of them would say, yes, this, that, and the other happened, but it wasn't that bad. But when I was able to help them see that it was much more impactful than they realized and give them some ideas on how to work with that. Sometimes they would need a therapist to help them with that, but a lot of times they could do self-treatment. In the early years, there weren't nearly as many resources as there are today. I mean, we've got the symptomatic.me website has a whole bunch of resources and a list of, in and of itself, and then a list of other resources that are science-based that people can use, the Curable app, for example. But in the early years, I would have people do things like write a letter to the person who mistreated them as a kid, not to mail it, just to write it, to put all their thoughts and feelings down. Once I could bring the emotions into their conscious awareness, then they would have something to say. And by expressing emotions in words, either written or spoken to a therapist, sometimes even spoken just to a recording device, you are converting the somatic expression of emotion, the bodily expression, into verbal expression. And the more you put it into words, the less it needs to be expressed into your body, for example. Another key one was carving out time in your schedule, if you possibly can, for self-care, to do things for yourself that have no purpose but your own joy. And this is a challenge for a lot of my patients. Many of them had never done this. They had grown up in environments where there was some kind of dysfunctionality going on that they had to pay attention to as kids. And so instead of paying attention just to their own needs, just to play, they didn't sufficiently learn how to do that. They didn't get enough opportunities for carefree play. So as adults, they are living lives focused on the needs of other people, just as they have from their earliest years. And sooner or later, living life on a treadmill like that, your body is going to protest, and you're either going to get pain or some other symptom or chronic fatigue, something that your body is going to force you to take care of yourself, even if it's only, debilitating you so much that you're flopped in bed most of the day, until you figure out how to do self-care.
Wow.
And what we're looking for there is the moral equivalent of finger paints for a 4-year-old. A 4-year-old with finger paints doesn't care how many pictures per hour they produce. They don't care about the quality of the work. They don't care who sees it. They just know they're having fun. And that's an essential human skill, having fun.
Yeah, that's funny. I was thinking play. Like it sounds like you're telling people to go play.
Yeah, and one of my favorite stories was a woman who I met in the early hours of the morning in the emergency room. She had acute abdominal pain. They did all the tests on her overnight, and they were all negative. And it turned out she had one of these never step off the treadmill lifestyles. She had been an athlete as a girl. She was coaching her daughters. She had two daughters. She was working full time. She was coaching other people's kids. She was on the athletic club board of directors. She was driving kids to out of state competitions. Her husband worked full time as well. I asked her, what do you do for fun? And she's kind of like, not really sure. Maybe I get to the movies every other month or something. So it never stopped for her. And the reason for that was that when she was doing her sport as a girl, she would practice before school, after school, and on weekends. And she started doing this at age 4. She never really got to be a kid. She had no concept of playtime. And her treatment was, and fortunately with her husband's support, she was able to do this. Not every person is able to carve out an afternoon a week, but she carved out an afternoon a week, get out of the house and just do something with, only for herself. It was a trial and error period of finding a enjoyable activity. It can take people months to learn how to do this. All she could think of to do was go for walks in a park. It's very common in my patients that I recommend this to find the playtime. They'll look at me and they'll go like, what am I going to do? What am I going to, what's fun? Gosh, I'm not sure. And that was her situation. All she could do was go for walks in a park. But while she was walking, she was thinking. And eventually, after about 6 weeks, she hit on the idea of taking piano lessons, which she had never done anything musical before, but she absolutely loved it. And her pain went away.
It's like the number one prescription that should be given for pain relief, right?
If you don't have it, yes. If you don't, have that skill, and I regard it as a skill, then yeah, you absolutely need it. If you're not doing it, all the other treatment measures are probably going to be unsuccessful.
No, I believe self-care is also not a skill that's promoted or talked about enough because it seems so simple. And also there is this belief that self-care is selfish and doing things just for yourself is considered selfish. So it's like a taboo to even think those thoughts of I need time for myself, much less actually taking the steps to taking care of yourself. And that's I think why it's such a big deal in these like developed countries is because there's this sense of like always having to do something, like keep going to make the money, to support the family, whatever it is. It's just a lot of productivity.
Yeah, I'm so glad you mentioned that, Camille, because it's an important piece of this is that people feel guilty when they do this. And it's important to prepare them for that, to say, yes, I'm recommending you go out here and do this. You're going to feel guilty because you're going to be thinking about, oh, there's dust bunnies in the living room I got to take care of, or I should be calling my friend to give them support. And all I'm saying is to put yourself on the list of people you take care of. That's all this is. But yeah, you're right. You have to prepare people for the guilt that is going to happen when they first start doing this. But it comes down to what they tell you on the airlines, put your own oxygen mask on first. If you really want to be of value to other people, you can't do it if you're slammed with chronic fatigue, for example.
It's the way society has become these days. I have seen more and more women with bladder pressure, urinary frequency, and PGAD symptoms. And when I go through their day with them, there are no breaks at all. It's helping kids with homework, working, going to soccer practice. No wonder why there's so much pressure on these women in their pelvis.
Yeah, no, I played soccer as an adult on amateur teams for over 20 years. I mean, that was my personal playtime. After being kind and compassionate to my patients all week, get out there and kick something. It was the best. And the team would go out for a beer after the games and, talk about anything but our work. Sometimes if it was a late indoor game, we'd go out for a beer before the game. It shows you how seriously we took it. But that was my personal stress relief.
Now, I'd love to ask you a little bit more about endometriosis because you brought that up Have you found from either your experience or anyone else that you know of that endometriosis, all of endometriosis, maybe some of endometriosis, maybe it depends on the person, like is that neuroplastic or are the different stages different? When people find lesions, is that the body actually producing a response, having an actual response to whatever it is? It's their personality, something was triggered, it's emotions, stress.
Yeah, it's a very good question. I think the more endometriosis that is present in a person's pelvis, the more the symptoms fluctuate with the menstrual cycle, the more likely it is that the symptoms the patient is having will benefit from treatment of the endometriosis. But one of the early studies, 1988, University of Washington, looked at two groups of women who were scheduled for laparoscopy. One group were having the laparoscopy for infertility evaluation or some non-pain reason, and the other group, the laparoscopy was for pain. And the findings at laparoscopy were the same in both groups. There was just as much endometriosis in the pain group as there was in the non-pain group. And same with ovarian cysts and adhesions. And it's also the case that surgery for pelvic pain is successful less than 50% of the time in alleviating the pain. It's better than the results of surgery for lumbar spine pain, but it's still not ideal, and it suggests that a significant fraction of the pain is not from what's going on in the pelvis, that it's neuroplastic, it's brain generated. So I certainly can't say that all of endometriosis is painless, but I think it's important to evaluate the patient completely, and that means doing what I call a stress evaluation, looking for all of those psychosocial issues that I described before you start doing invasive treatment on somebody. Make sure you've been thorough. Yes, you've done your ultrasound and you found the endometriosis, but you should also be looking for any stresses in their current life that link to the fluctuations in their symptoms. If their pelvic pain goes up whenever they visit their mother-in-law, that should tell you something, and you should be looking for that kind of linkage.
Wow, this really reminds me of, in physical therapy school, we learned about herniated disc and we talk about chronic low back pain because it's very common. And, we were taught in physical therapy school that herniated disc isn't always the cause for chronic low back pain because when they sample random people from the population, people who don't have pain also have herniated disc. So that's not necessarily the cause. And what you just said just reminded me of the same exact thing.
Yes, you're absolutely
Yeah.
right. The majority of people over the age of 40 have abnormal spine MRIs, and that's strictly people with no symptoms. I should have mentioned in that study with the laparoscopies, the biggest difference between the pain group and the no pain group is that the pain group had a history of childhood sexual abuse 3 times as great as the no pain group. So that was the big difference between the two groups. There was a parallel or supporting study from a specialty pelvic pain clinic, I believe at the University of North Carolina, where they surveyed them all for a history of childhood sexual or physical abuse and found that 50% of the women in that clinic had that history, huge proportion. And the ones that did, their symptoms were all worse and they were less likely to improve.
I know that Tarlov cysts can fall under this category as well. I actually have 2 Tarlov cysts. I've actually had them evaluated, and thankfully, I did not even have the surgery to get them done. But I'll have women calling me all the time saying, but I have a cyst, it's there. But I believe that most of them are asymptomatic, as are mine.
Yeah, no, in that study from the University of Washington in 1988, I mean, a third of the women with no pain had endometriosis or adhesions or an ovarian cyst, no pain. And the success rate for surgery on the lumbar spine in one study correlates with the magnitude of the adverse childhood experiences that you've been through. If you had no ACEs, as we call them, in this study from the early 90s, they had a, 95% success rate for the lumbar surgery. If you had 3, 4, or 5 out of 5 ACEs, nowadays we talk about 10, but in this was before the original ACEs study. If you had 3, 4, or 5 ACEs out of 5, the success rate for the lumbar surgery was 15%, 1-5. And
So
the reason is that because they were operating on something that wasn't the source of the pain.
Right. So I was going to say, it seems like what people need to work on is past, like considering, as you mentioned, what may be causing stress now and what could have caused stress in the past that's still living in your body, basically, as you mentioned, unrecognized emotions. And I like the technique that you had mentioned is having them be like the butterfly or the fly on the wall and having them experience the life of that child. How does it affect you? Because that's a really good way to judge. Oh, yeah, I would be bothered by that. And that's a clue that maybe you haven't fully addressed it yet.
Yeah, absolutely. I tend to watch my patients' facial expressions when I'm describing that exercise to them. And, often they will get this, oh my God, change in what their face looks like when they hear that. One of my favorite stories about that is a patient who was denying up and down that her childhood experience was having any impact on her. But she was in her late 30s. She had 20 years of neuroplastic symptoms, anywhere up to 5 or 6 at a time. She also had another consequence of childhood adversity, which was choosing bad partners for herself. She had basically a new boyfriend about every 18 months, and they were all bad. And her story about childhood stress was not physical or sexual abuse. It was that her parents verbally and emotionally abused each other throughout their marriage. And she was the only child, and so she played the role of the peacemaker. And of course, as a young girl, she wasn't able to have an impact on her parents' problems, and so she felt like a failure. And low self-esteem is a big common denominator in people who come out of an ACEs environment, something that I consciously try to reverse for people. I try to help them see that, what they went through was the moral equivalent of being parachuted into a dangerous jungle as a toddler, and that they need to give themselves tremendous credit for having survived that environment. But this woman was not buying it. And her parents then divorced when she was 8. So I'm thinking, okay, at least she got a break from this problem at that point. Unfortunately, that turned out not to be the case. Even though the parents divorced, they kept living in the same house. They slept in separate bedrooms, but they kept living in the same house. And so they were still at each other every day. And as far as my patient was concerned, nothing improved. So, until she left for college at age 18. So just, terrible experience. Clearly the reason why she was still having symptoms all over her body at age 36, but she wasn't buying it. So I said, okay, we're going to do this butterfly on the wall experiment. She didn't have any kids, but she had a beloved niece, 5 or 6 year old niece that, she just adored this little girl. Took her shopping, took her to Disneyland, took her to, all kinds of fun activities. I said, okay, imagine your niece in that household trying to deal with your parents. You're a butterfly on the wall and you're having to watch her try to cope. How's that going to be for you? And she just stared at me. She was in a profession that involves a lot of verbal communication, just had no words and just processed this for a couple of minutes. And I just, waited to see what her reaction was going to be. It didn't say anything. And finally, she says, at the end of a week, I would shoot myself. And that was the first time she truly recognized how bad it had been. And then I try to couple that with, give yourself some credit for having come through this. You have shown heroic perseverance in that environment. You ought to truly recognize how difficult this was and how heroic it was of you to make it through all of that for so many years. And that helps to flip people's self-image, helps them begin to build their self-esteem up to a level that it deserves to be. And that changes a lot. It changes their personal relationships. It changes their tolerance for being mistreated by others. It supports them setting boundaries with toxic people who are still in their life. It supports them feeling less guilty when they put themselves on the list of people they're taking care of. Lots and lots of positive domino effects from that change in self-image, and made a huge difference for her. She actually dumped her boyfriend the next day. By, I would say, a year and a half, 2 years later, symptoms were essentially gone, and she was, for the first time, in a healthy, mutually supportive relationship.
What do you say to people who feel like that woman, for example, you got her to recognize and see some things? They might be expecting symptoms, or someone else might be expecting symptoms to change overnight. How do you keep them moving in this direction when it's been 6 months and maybe they're feeling less pain, but maybe it's still there or it comes and goes? Like, how do you help them see the light at the end of the tunnel?
Yeah, it's a real challenge for people that are, make some initial progress and they're becoming hopeful, and then their improvement stalls. And I actually have a whole talk that I give on what to do when somebody's progress stalls. And a lot of it is about identifying the long-term impact of the ACEs that still haven't been addressed yet. Are there personality traits that were learned as a kid that are still there? Are there triggers still in a person's life that they haven't been able to put boundaries around yet? Are there buried emotions that haven't been brought into conscious awareness? Have they been doing enough self-care time? Those kinds of things are what I look for to try to help people keep moving forward. But if they've made some progress, that's often very encouraging, and shows that by doing the same things that they can resume moving forward again. But yeah, it can be challenging when you're not consciously aware of an emotion. It takes a lot of experience to help somebody like that to connect with that emotion. Some of these patients are very complicated, and their emotional issues are really buried, and they don't know they're there. And for you as a clinician to figure out what's there and help the patient to see it, it can definitely take an experienced therapist for some people.
So I have seen over 25 doctors over the course of when I was healing, and I was told I was crazy. They had no idea what to do with me until I found someone that understood the mind-body connection. So I'm just curious, how do you or other people, how are we getting the word out now to medical professionals to understand neuroplastic pain more?
Yeah, well, I give a lot of presentations on this. I mean, I've done 24 this year. I've done 36 television, radio, or podcast interviews like this one. We've just launched the new website, symptomatic.me. A number of our board members give presentations on this, both to the public and to professionals. We are supporting research because research is what is most convincing to medical professionals in particular. And we've got, half a dozen studies that have been published already and more on the way. And when those come out, they tend to get media attention. We've had articles in the Washington Post and the LA Times written by one of our board members who's a journalist. And we've got 3 documentary films out there. We have 2 textbooks. We're lots of things, and we're trying to grow. We have a membership program now that people pay annual or monthly dues. They get a lot of benefits in return for that. but the money from the membership supports our staff, and we've got 2.5 people now working on helping us get the word out. So it's happening. It's still tiny in relation to the need, but when I think back 15 years, even that recently, few of us who were doing this work knew that anybody else in the country was doing it, as recently as that. So, and now we've had this wonderful conference in Boulder, almost 270 people attended, and the surveys from it, obviously we do a post-conference survey, and we look at would you recommend this conference to a friend or colleague? And you can calculate a numerical score based on that question. And there's a standard way of doing that. 40 is considered a good score, but it's about average for American businesses. 50 is very good. 60 is over the top wonderful. Our score was 80.
Wow.
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 And it
And
was a
all
great
those-
conference.
And all those people are going out there and helping us spread the word. So I think of it like the snowball has been pushed off and it's starting to roll.
Yes, it's picking up momentum. And I do agree that people are becoming more aware of this, medical doctors, different kinds of practitioners, professionals, and the public. Like people are becoming more aware of these things because of, like you said, your articles, the documentaries, the books, the podcasts. It's just, we have to continue to openly have these discussions to let people see that this is a potential, it's an option, there's another way. You don't have to live like this forever.
Yeah. And when patients who have been successfully treated using these methods go back to their doctors, and we hope they will advocate and tell their doctors, hey, this helped me. And that can encourage doctors to refer more patients. Not every doctor wants to learn how to do this themselves, but if they have good behavioral health consultants backing them up, then it can work extremely well. If both the behavioral or mental health professional who collaborates with the physician, if they all learn how to do this. One doctor took me aside at a conference after that, after learning about this, and said, this has put the joy back into my work. Because all of a sudden, 40% of her practice, who used to make her beat her head against the wall, now they're a source of rewarding outcomes. You see people who have been ill sometimes for decades suddenly getting better, and doctors love it. That's why they're in the business. They like to heal people. And there was a class that I did because I knew doctors didn't necessarily want to do this themselves. So I started a class for patients who quote unquote might have stress involved in their illness. And I promoted it really heavily to probably 80 or 100 primary care docs. And the first class, only one patient came.
Wow.
And I went home to my wife and said, I'm going to cancel this thing. I am so pissed off. And she said, no, keep going for a little while, see what happens. And next class, 2 or 3 people, and then it was 5 or 6. And they were all going back to their doctors and telling them that the class was useful. And so doctors were encouraged to send more. And after a couple of years, I was seeing 50 patients a month in that class.
Wow.
So if you can get a feedback loop going like that, that's going to help move the snowball.
Yeah, that's great encouragement.
So for people that are listening right now that are having chronic pain, I'm just wondering if there's one thought you would want to leave them with.
Well, I will just say that there is tremendous hope, and people often wonder if there's anybody else out there like them. And if you have been to physicians and had your diagnostic evaluation and they're not finding anything to explain your condition, or they think they found something, but the treatment of it is not working the way they expect it to, then that means you have a lot in common with 50 million other people in the United States that are suffering from this. And even people with severe versions of this can get better. One of my patients I was asked to see on hospital day 70 straight days in the hospital, getting morphine around the clock in doses you'd normally associate with somebody with, bone cancer. She was successfully treated. Another patient, 27 different distinct symptoms all over his body, successfully treated. The patient with 79 years of abdominal pains, registered nurse, plenty of access to health care, 79 years, successfully treated. Another patient hospitalized at a prestigious university hospital 60 times in 15 years. This is a first story in my first book. My first book is called They Can't Find Anything Wrong. I love this story so much. 60 times. And when I went to see her, she had attacks of vomiting and dizziness. And I went in to see her and she said, "Doctor, don't waste your time with me. You'd be better off seeing your other patients." She was so hopeless. And I said, "Why? Why don't you want me to do an evaluation?" She said, "Well, I've been hospitalized at this big university. I've seen a dozen specialists, including a psychiatrist, and they can't find anything wrong with me. So, don't bother." But, obviously I couldn't resist a challenge like that. So sat down, talked to her. Less than an hour later, she was not only diagnosed, she was cured.
Hope.
Absolutely. Absolutely.
Well, thank you so much for being here with us today. We really appreciate your time and all the work you do in getting the message out there.
Thank you. Thank you for having a platform to help get the message out there. We didn't have this 15 years ago, so I'm delighted to participate.
Yes, thank you so much.
Thank you.
If you'd like to leave us a message or ask a question, please check the show notes with the link so you can reach us directly, or email us at beyondthepelvis@gmail.com.